Are you going to mute our lines too then?
Yeah, I am. I'm going to mute.
Hi, this is Tim. I'm on.
Yay.
Okay. It's 3 o'clock right now, so I'm going to jump in and we will launch.
Awesome.
Okay, perfect.
Fantastic. So,
Okay,
Greg,
Oh.
All right, everyone. Well, thank you so much for joining. My name is Byron Crow. I'm a physician and associate medical director at Solera Health. I'm joined by some of my colleagues from Solera and from the YMCA USA, and we're really delighted to be able to share with you today a little more about our unique partnership to support the launch of CMS's new care model, the direct contracting entities coming up in the next few months, and some of the ways that Solera and the Y USA and local and regional Ys can help support the ongoing move to value-based care redesign that's being supported by the DCE model. A couple objectives for today. The first, at a high level, introduce you to this partnership. How does Solera and the Y work together, and what kind of synergies will that add to your organization as you move forward into DCE? And then specifically learn how the Solera and the YMCA can help you address the social determinants of health and provide some pathways to address chronic disease management. And then we've done this presentation before. We find that it takes about sometimes 35 to 45 minutes. So we'll have some time, plenty of time for questions at the end. And of course, we're happy to answer questions offline too, but we'll get through the presentation and then we'll save some time at the end for everyone to ask us whatever questions come to mind. And then again, I already introduced a little bit about myself, but I'm also joined by Tim McNeil. Tim, could I have you give your introduction and a brief background?
Sure. So my name's Tim McNeil, and I was a consultant for the U.S. Administration for Community Living and worked with a lot of nonprofit organizations, including YUSA, YMCA the USA, all around value-based payment models.
Fantastic. Thanks, Tim. And Tim will be talking more about the Y a little later in the presentation. So I'll start with about Solera, who we are, what we do, and how we fit into this. So Solera, we are an organization that creates networks of predominantly non-clinical programs, community-based and digital programs that prevent and manage chronic disease and address the social determinants of health. We create networks of those programs. We then match consumers to the best fit program for them. They can onto our website or through our call center, tell us what program they're interested in, and then we ask them some questions to try and figure out exactly what is the best fit from the many programs that might address a certain social determinant or chronic disease. And then once we've matched someone to a program and they go through the program, we can manage vendor payments and claims from payers and providers across the continuum. So we can file medical claims with healthcare payers who contract with us to get access to our network. And as individuals progress through programs, we file claims on behalf of the vendor, we get paid from the payer, and then we provide payments to our network providers. So we manage all the payments from end to end, and then we layer on robust reporting and analytics to identify who's successful in these interventions, what the outcomes are looking like, and how we can iteratively improve the programs year over year. So we got our start predominantly with the diabetes prevention program. We have put over 200,000 people through our diabetes prevention programs to date. But now we're taking that national network concept and building it out across a variety of different health domains, including chronic disease management. You can see at the top right some of our chronic disease management interventions. So diabetes remission, weight loss, intensive behavioral counseling, smoking cessation, falls prevention. Then social need, addressing the social determinants of health we just went live with our social connectivity program addressing social isolation in older adults. And then we'll be going live with food and nutrition here in 2020. Then for behavioral health, we also are building networks to address stress and resilience, kind of preventive mental health, as well as clinical anxiety and depression. And all this is underpinned by really a core value proposition that, you know, when you go out into the clinic and get care, that's pretty straightforward. You know, if you need a colonoscopy or you need a flu shot, you can go to your doctor, and the mechanism to get value from those preventive interventions is well known. You know, you can find a doctor in your community. But there are these amazing digital and community-based interventions that certainly address chronic disease prevention and management, but also address social determinants that are not linked to the formal healthcare ecosystem, but can provide tremendous value to members of a health plan or people who are networked with a health system, or individuals who are in a direct contracting entity and part of a value-based care model. So part of what Solera does is we can create networks of these programs in a way that we can start to extract the value of those programs by actually directing members into those programs and managing it very much in the same way that you would manage a network of actual clinical providers. So why Solera and the YMCA? How did the two of us together, how are we greater than the sum of our parts? So from the Solera side on the left, Solera, as I described, we're curating these high quality, non-clinical programs and providing a turnkey method that connects patients to these programs that improve or maintain better health. And with the YMCA, we have a tremendous partner who has a national reach, on the ground, offering these programs to tens and hundreds of thousands of members all across the country. And we're really excited about this partnership where we can bring our expertise in creating and managing networks of non-clinical providers with a partner with such a tremendous national reach and expertise in delivering these programs in neighborhoods and communities and meeting people where they are in their healthcare journey. And all of this is to support the CMS direct contracting and primary care first payment models. So we think that there are several threads to this as people transition into a more value-based care model. First, obviously, this partnership is designed to improve clinical outcomes. These programs are preventing disease or managing the complications of disease, managing the burden of the social determinants that can worsen disease. But we're framing this all around a way that we can try and reduce total cost of care and reduce the growth of healthcare costs for key stakeholders. And of course, all this as part of our mission, not only to improve health, but improve the social condition of individuals that leads to poor health. So how do we actually do this? A few ways. The first is we've talked about our network, but a major thread of this is our technology-driven platform. So we have a great platform through Solera, and then in 2020 our Solera's new platform that allows us to really integrate immediately and directly with community partners through APIs and all that good stuff. And then our network solution allows us to identify a range of evidence-based interventions and create networks around that. And then all of this is part of a broad market infrastructure that has a large national reach. I will stop there from the Solera side. I'll turn it over to Tim. Tim will talk a little more about the YMCA's programs and how the things that the Y is doing on the ground fit into this overall model. So Tim?
Great, thank you so much. So as many of you all know, YMCA is much more than a gym and swim. We, several years ago, embarked upon establishing an infrastructure to deliver a range of evidence-based and evidence-informed interventions with a specific goal of integrating with health systems to drive improvements in clinical outcomes and reductions in total cost of care. And when we say evidence-based and evidence-informed interventions, that means that many of our interventions that are evidence-based have undergone randomized clinical trials so they can prove the evidence of reducing and improving outcomes. And our evidence-informed interventions, oftentimes there's been replication at multiple sites, but haven't undergone the same rigor, but we have documented improvement in outcomes and reductions in total cost of care. So this listing shows the wide range of interventions. And as many of you all know that are embarking upon the process of direct contracting, that you are allowed and encouraged to incorporate wellness interventions, wellness programs into your application, with the caveat that you have to define the model of delivering those programs and also submit to CMS for their review an implementation plan. The nice thing about working with YMCA of the USA and the broad network of YMCAs, most of your beneficiaries will be within a few miles of a local YMCA. And many of these programs, some range of them are available at almost all of the YMCAs across the country. So you would be able to customize the delivery to the patient. So it would be a patient-centered approach to developing a plan that includes one or more of these interventions. Then the beneficiary could participate in these interventions and be part of the direct contracting model of care that's delivered to beneficiaries. So an example, we have multiple fall interventions that are listed. One innovative way that we discussed with the Centers for Disease Control is that we have providers that are entering into risk-based contract models where they are screening for fall risk. Those persons that screen positive for moderate fall risk, the study algorithm recommends that they are referred to a CDC evidence-based fall prevention program. Well, voila, many YMCAs are implementing a CDC-recognized evidence-based fall prevention intervention that would be the conduit to addressing fall risk in that beneficiary. And through this partnership with Solera, we'll be able to capture the pre and post data regarding fall risk, document the participants' completion of that intervention and what that outcome is, and then submit that completed evaluation back to the referring provider, closing the loop on the care for that person. Next slide. So a sample market I'd like to highlight is the YMCA of Western North Carolina. And it just gives an example of how a local YMCA engaged a large health system in their community, and that large health system was embarking upon a value-based payment model. It was not direct contracting, because obviously direct contracting is new, but it was a large ACO in their market. That health system and the Y began looking at a range of different interventions. So the listing are all of the interventions that the YMCA and their health system partner identified and began implementing based on the needs of the population that was determined through risk stratification that was developed by the ACO. So the process was the ACO risk stratified their population. They identified specific needs amongst that population. Then they collaborated with their YMCA partners to develop interventions, evidence-based and evidence-informed, to address the needs. And you see it goes everything from phase 4 cardiac rehab to increase access to the community food bank for persons who screen positive for food insecurity. So clearly the Y is a close partner in the delivery of healthcare services for a targeted population and is a key to the intervention strategy. We see the opportunity for direct contracting in a similar way, where direct contracting entities that are preparing their application can begin developing a custom approach to targeting the needs of their population that can match with the available programs that are at the Y and incorporate those programs into the direct contracting application model. A key aspect of the example on the screen, as well as in direct contracting, as you all know if you've been preparing the application and going through the CMS webinars, DCEs, direct contracting entities, will receive a per beneficiary per month payment. And in that, if they are proposing to implement wellness interventions, they're also supposed to speak to how they will utilize the per beneficiary per month payment to make those programs sustainable long term. So this infrastructure that the YMCA has obviously is not free. There's cost, there's coaches, there's evidence, there's researchers that are supporting these programs. All of that then gets incorporated into the cost, but the health system doesn't have to pay for all the research and development and implementation of these programs. All they have to do is partner with the YMCA, who has a strong history of delivering these programs in unique areas in the community. Next slide. So another thing I would like to highlight is person-centered planning and shared clinical information. And so as part of this model, and ones that we've begun to experience across the country, where YMCAs are partnering with health systems that are entering into value-based risk models, is person-centered planning. And so it's one thing to have a passive way where there's programs at the Y, there's a health system operating in that community, and there's no matching of the needs of the beneficiary to the strength of the programs at the YMCA. So a person may go into a local YMCA saying that my doctor referred me here for weight loss because I have prediabetes. And in order to avoid those complications, I need to do some weight loss activities. And that person may have no understanding of the full range of interventions available to them. And that's where a person-centered planning approach can come into play, where that person could be matched with a YMCA health coach. That health coach can assess the range of that person's needs and then custom a package of services to meet those needs, and then assist and motivate and navigate that person through the YMCA system to achieve all their objectives. And what we found is sometimes persons that present with one problem, actually, if they have multiple comorbidities, they can benefit from multiple programs. So the earlier slide that identified the wide range of programs, a good example of two programs that often there's cross-pollination are diabetes interventions, as well as our hypertension, our blood pressure self-monitoring hypertensive intervention. Oftentimes, persons that have a history of obesity, diabetes, complications of diabetes may also have hypertension. And they may not know that those programs complement each other well, and that at the same YMCA or the network of YMCAs in their area, they can participate in multiple programs. The same thing occurs with persons with multiple chronic conditions and fall risk. The health coach could help develop that custom package and then navigate the person through, and that could be part of your submission to CMS as your custom intervention of wellness programs that you will implement as a DCE using the partner infrastructure of the YMCA in your local community. Next slide. Oh, sorry. So we're already on the slide. So diabetes. The example of in Western North Carolina was that they also identified that diabetes was ravaging their community. As a result, and the health system also identified that they had always had diabetes education programs that were incorporated into the health system. However, it was not reaching very many people. In fact, CMS's Center for Medicare and Medicaid Services data shows that only 5% of people with a diagnosis of diabetes ever receive diabetes self-management education training. And so what this community decided was they needed to increase the access points for diabetes throughout the community as a complement to what was available in the health system. So the YMCA identified local touch points in the community that could be a wide range of access points. And in addition to the clinical education that was provided by dietitians, the YMCA created a custom health coaching model as an extension of that education. So an example of that is that a person would come in and they would receive dietary education with the dietitian that would talk about carb counting, label reading, and then subsequent to that, the YMCA would take a field trip to the local grocery store. They would walk them through the aisles, show them how to read the labels, and show them how poor decision-making in your food choices leads to worse outcomes, and that was then communicated back with the dietitian. So another example of how a unique implementation strategy that could be part of your overall direct contracting entity population health strategy, leveraging the wide access points, the range of access points, and the expertise of the local YMCA to deliver those programs. Next slide. So the listing of the evidence-based and evidence-informed programs also includes fall risk in older adults, adult BMI, monitoring physical activity, comprehensive diabetes care, cardiovascular care. So these things within organizations that have already participated in value-based payment models, such as ACOs, will have resonance with you because they align with the clinical quality reporting measures that you are held to under those other payment models. We do understand that the clinical quality measures under the direct contracting application are much streamlined, more focused on cost instead of specific measures. But on the other side, we do know that if you improve these measures, you will achieve the cost saving and reduction. And traditional models of bringing everyone back to a health system doesn't meet the needs of the entire population. So the partnership with the Y enables a health system that's entering into this risk model to engage more of their population in more settings that are more comfortable for them. So we're seeing increased completion rates amongst the people that access programs at the local YMCA. Next slide.
Great. Thanks, Tim. And I think that is a really nice segue into a couple other thoughts on the model here. And I just wanted to point out one quick slide on addressing high cost, high need older adults. And we're not going to go too in depth to this today, but it's more of a bookend to say, so much of what we're talking about is focusing on, certainly the general population, but especially high cost, high need patients. And we can talk a little more about how these specific interventions get to that a little later. So as we alluded to, so much of health is driven by socioeconomic factors and health behaviors, and outside of even beyond just the walls of the clinic. I'm sure many of us have seen some variation of this slide before, saying, okay, healthcare, direct provision of healthcare is responsible for 10, 20% of healthcare outcomes, and health behaviors and socioeconomic factors are responsible for so much more. And one of the great things about this collaboration is we're able to target interventions across this continuum. Certainly the health behaviors component, so much of what Solera does is focused on chronic disease management and prevention, so much of what the Y does and the interventions that Tim just listed, and then layered on this community-based support for, on the top right, you can see the 68% of Americans that face at least one social challenge, whether it's financial insecurity, food insecurity, social isolation and loneliness, the list goes on. And addressing those socioeconomic factors and social determinants of health is a big piece of this that we certainly don't want to understate. So one of the great parts about this collaboration is that in addition to some of the work that the Y has already done with identifying at-risk populations, Solera can complement that with our data and analytics approach that helps to identify social risk and gaps in care. It's when someone comes in with a hemoglobin A1C that says that they're in the pre-diabetic range, it's a little more straightforward than trying to understand all the complexities of someone's social economic situation. But we have the data and analytics capabilities through partnerships that Solera has and partnerships through the Y to actually identify what social care needs members have and direct resources toward those members. So a large part of what we're proposing here, and we'll get to this in a few slides, is not only the intervention piece, but the risk stratification and identification component that we can layer on to support DCEs and figuring out who their members are that have needs and directing the interventions in a very targeted way toward those members. So even before that, Tim made some great points about being able to customize interventions and really drill down and meet the needs of specific DCEs at the local level. And I'll talk here about a little more of our general interventions that we can create networks locally, but that play to the existing networks that have been developed by Solera and the YMCA. So could you go back one slide, Greg? Thanks. Great. One component of this is, as the DCEs roll out, Solera and the YMCA can offer several evidence-based programs right off the bat with proven ROI to start delivering early savings in the model. And I listed 3 here, but our diabetes prevention program, which, as we said earlier, is our main program, the one that we've scaled the widest. But then we have exercise and balance training for falls prevention, which is live in the market now. And then senior wellness programs through the YMCA, which have demonstrated savings across participants. So we have the ability to turn these preventive interventions on right off the bat to start generating savings at a population level, alongside a more targeted approach that identifies patients at a more granular level and targets specific interventions to them. Great. We can skip through this slide. So I want to talk about the 5 steps in this new care model value chain that we're proposing for at-risk Medicare providers starting in year 1. So the first step, as I alluded to, is the Solera and the YMCA can immediately deliver evidence-based preventive care programs with documented ROI to start driving early savings in the model. Then in the second step, Solera can layer on consulting services to co-design innovative lifestyle medicine and social care benefits that start to bring down total cost of care. We are always on the search for evidence-based programs that are generating savings and providers, network providers that are able to deliver those programs. And we've developed quite an expertise in what the market looks like, what interventions are out there, and how they can be directed towards members. Then in the third step, Solera and our analytics partners can work with the DCE to identify the specific medico-social needs of the at-risk population. And then from there, once we've identified those specific needs, in step 4, we can curate and manage a network of local providers to deliver those chosen interventions with the YMCA as a strategic community partner. And then the 5th and final step in this iterative cycle, Solera can provide the data and analytics support to assess the impact of those innovations and start to drive iterative change, figuring out, hey, if we have these custom programs, are they working? Who are they working best for? Which ones should we bring to scale? And which ones should be either redesigned or tabled and to make way for a new intervention. Again, this is getting at this list of our capabilities between the Y and Solera. Now, on the left, you can see all the many interventions that are offered by the Y and our network partners through Solera, spanning the spectrum between chronic disease management, so diabetes prevention program, diabetes self-management, Parkinson's, cancer survivorship, through some of the social determinants of health, medical or housing insecurity, medically tailored meals, social connection. But then, we can take these interventions as a one-off, like the list on the left, but we can also bundle them together and direct multiple interventions toward members. So for members who have heart disease, we can create bundles to specifically address cardiac issues, smoking cessation, medically tailored meals for heart failure, medical nutrition therapy for folks who've had MI, intensive cardiac rehab, et cetera. Or what about folks who are leaving the hospital who may need supportive housing, may have financial issues, maybe start to feel socially unconnected or lonely? We can wrap around these services in a bundled way that starts to create synergies more than just a pick and choose, one-off type intervention. Go to the next slide, Greg. And then all that, just to reiterate, we take the mindset that everyone needs help sometimes. You saw that a few slides ago, 68% of Americans have some kind of social need. And what's really nice about our approach is we can use our social propensity scoring data to identify who needs help and when. And those people may be maybe an unexpected parts of your population that they have a very specific need that may be impacting their health rather than sort of more traditional risk factors. But we can slice and dice the social data, claims data, public health data to come up with a solution that combines social solutions and disease-specific solutions. And then all this, to reiterate on how this plays out, is designed to support both implementation of proven programs as well as a continuously learning healthcare system. So let's say, for instance, there's a cardiac care bundle. We can identify that population, target members toward those interventions, and then iteratively evaluate clinical and cost outcomes, and iteratively improve the program over weeks and months, not years and years, and then bring success to scale, or quickly identify programs that aren't working and table them to make room for things that do work. So here's just a roadmap of what this looks like in years 0, 1, and 2. As the model starts moving forward and folks aren't at risk, we can help prepare outreach strategies and a game plan for delivering positive ROI interventions, as well as start to identify and stratify members by medical and social needs, so that in model year 1, when folks go at risk, the pump is primed to deliver those high ROI programs at scale immediately, start to generate early savings, while also implementing the more customized interventions, the more experimental interventions that may drive longer term savings. And then, in model year 2, once the high ROI programs has been rolled out, continue to optimize those while expanding the suite of innovative interventions that are being offered. One point here that we like to make, though, is why we think a network-based approach is superior to a different screen and refer approach, where just asking members a couple questions here and there and referring them to the existing resources in their community, a more unstructured resource. And we think there's a lot of value from, at the very top, this intentional network design that Solera is able to offer. We can find network partners who do very specific things and then direct members towards them in a thoughtful way, rather than kind of sending people out into the ether to sort of take advantage of whatever they can find in the community that may not be as intentionally directed at their specific needs. And then, because we're able to offer financial reimbursement to our network providers, that creates a certain level of stability. I'm sure we've all experienced at some point an organization we've worked with that's grant funded, the grant runs out, and now that resource is gone. But with actually partnering with folks and paying folks to deliver these services, we can de-risk those providers significantly. And then we hold our network partners accountable for outcomes. We choose partners very carefully to make sure that they're able to offer the intervention and actually deliver the clinical outcome that they want. When a screen and refer approach, you're really at the whim of whoever is out there in the community, and hope they can deliver. But and then with our networking, or with Solera's network approach, we do all the contracting for our networks, and we've heard over and over again from our payer partners about the burden of contracting with multiple community-based organizations, especially organizations that don't have as much experience working directly with healthcare providers. And Solera has developed significant expertise in that through our work with DPP and creating other networks. And then finally, more of what we talked about, but Solera can layer on advanced analytics and reporting to drive iterative improvement. We can easily scale interventions that work by going out and finding more network providers. And then we have many years of experience with outreach and engagement around finding members and plans and directing them toward the best fit program for them. Great. Then here we have just a couple other thoughts. This gets back to some of the things that Tim was mentioning. We have in the DCE application some of the proposal scoring requirements. The YMCA and Solera can deliver interventions that are getting at exactly the kinds of things that CMS is looking for in their application around patient engagement incentives and many of the things that are seen in that RFA are present in the programs that we're offering.
One additional thing. Can you hear me?
Yeah,
I was muted.
Go ahead, Tim.
Oh, sorry. I thought I was muted. So one additional thing that I also wanted to point out was that DCEs can offer a patient incentive, a financial incentive for participating in wellness programs to entice them to enroll and complete those wellness programs. And the request for application specifically states that a DCE can provide a financial incentive to the beneficiaries up to $75 per year per beneficiary for satisfactory completion of a wellness activity or program. And so again, they have to, in order to use that or leverage that, you have to have an implementation plan. And we have a turnkey solution of an implementation plan that would then be sustainable long-term, plus provide a pathway to provide a financial incentive so that DCEs will be more attractive to beneficiaries that are making the selection and could then sign up with the DCE that has this package of benefit services. So additional sections in the RFA speaks to the Chronic Disease Management Reward Program. That's on page 25 of the RFA, and that's where it outlines the financial benefit. Key hallmark of this engagement is developing what that program would be, how you would then verify people completed that, a beneficiary completed that, and the outcomes. And that's where we would work with the YMCA and Solera team would work with a DCE applicant that would then custom a service delivery model that help develop a reward incentive if they so choose to have one, as well as define what the cost points would be for their patient population accessing these programs as an enhanced benefit that the DCE could provide to their population that was aligned with the DCE. So this community integrated approach really helps one define the market reach of the DCE providers, align that to the markets where there's YMCA associations and matching that to the existing programs at the Y. So that long laundry list of programs that I was in an earlier slide, we would identify the specific programs that are immediately available at the YMCAs in the local market of the DCE applicant. We would also review that list to see if there are particular areas of concern for the DCE where there may be a gap where maybe the YMCA doesn't have that program. And then we can work with that local Y to see if there is a on-ramp to develop that program, if it would be sustainable by incorporating the cost of delivering that program model into the DCE program application. Next, we would define that business model, define the implementation plan, and then help provide a turnkey response to CMS addressing that issue of how you would meet that needs of the population through this YMCA Solera partnership. So additional areas that the YMCA Solera approach provides is, and it speaks to specific points in the application. So as you know, at the end of the request for application is the scoring rubric or the evaluation criteria, and the evaluation criteria is scored. And there are specific areas in the application that we believe we have the YMCA Solera partnership has unique value proposition to a DCE applicant by meeting some of these targeted requirements that are in the scoring methodology for the DCE applicant. So one is you have to define beneficiary outreach, patient caregiver engagement, and shared decision making. Well, clearly beneficiary outreach, what better beneficiary outreach could you have besides the broad reach and network of the YMCA and the local community that's as an extension of the health system or healthcare provider that's applying. Patient caregiver engagement and shared decision making. With all of our program interventions, we don't just start with the beneficiary, but we look at the entire family caregiver infrastructure. And in many of our classes and programs, we encourage the family members to also be participants. So a good example, our diabetes programming. Oftentimes, the person that's impacted by diabetes may not be the person preparing the meals. So if I'm spending a lot of time discussing food preparation for a person that's not participating in food preparation, will I achieve the outcome? So we recognize that and actively engage all of the family members to participate in these programs. So again, really speaking to how we will achieve patient caregiver engagement, shared decision making. I spent a good bit of time talking about our approach to person-centered planning, which is a key component of the shared decision making process. Providing care that's integrated with community resources. The YMCA is probably the best known local community resource there is. So having that as part of your application, knowing that you get points towards your application in the evaluation criteria for meeting this objective, the YMCA definitely would fulfill that requirement. Routine assessment of beneficiary experience of care. So as part of the core process of the YMCA is to provide ongoing continual evaluation of the member experience. And I mean member experience at the YMCA. We analyze that intensely, and that rolls into our evidence-based programming, so that we are trying to understand how we can provide continuous quality improvement of the programs so that we are consistently meeting the needs of the target population. So those are things that are carnal to our process. And the use of interdisciplinary teams to address whole person care. As I explained, we would have patients that would be referred to the Y, would be matched with a health coach. That health coach would be part of a team of trained program leaders that would deliver the classes, obtain the outcome metrics that are expected, and report those back to the referring provider, case manager at the health system physician practice that referred that person. So you could see the Y as an extension of the clinical team into the community, meeting the needs of the beneficiary where they reside. All of that would significantly enhance a DC application besides presenting the traditional clinical model, because clearly CMS is looking for something different than a traditional clinical model in the responses from a direct contracting applicant.
Great, thanks, Tim. This is just building on, all the things that Tim said in terms of value from the application standpoint, and on top of that, we think that there's a lot of value here from delivering the short-term ROI in terms of generating early savings, and then the continuous quality improvement that Tim mentioned around once folks have enrolled in some of these more custom programs, how do you actually leverage data and analytics to get them through the program and find who's succeeding and who's not. and then doing this in a way that, like Tim said, is this extension of the clinic that attracts folks to organizations who are doing these kinds of things, and are meeting their members where they are.
So at this time, I'd like to open up the line for questions and answers. We do have a little bit of time, and I do welcome your questions and answers. So the floor is open, and the lines are all unmuted.
And just want to remind everybody that the webinar is being recorded. If you're more comfortable typing in your question, feel free to do that as well.
And to that point, these slides will be available to all participants, as well as a link to a recording of the presentation. No more questions.
We have Greg, we do have a question in the chat from Christian Engel. How do cost payments work, and how is it the fee for service? So maybe.
Hi, so this is Jim. I'd like to address that. So the way that we do this is that you saw the long list of programs. We'd identify the market that the DCE applicant serves and the catchment area, get some understanding of the population. We would then look at the distribution of YMCAs in that market and the programming. And then we would discuss the programming, the interventions that are desirous to the DCE, and we come up with a custom package. So we don't have kind of a standard price for this package of service. We customize it to the market and the need of the DCE based on the population they serve.
Great. And then it looks like there's a question here from Tom. Have you ever had to partner with other folks? We don't have YMCA here. It would be possible here, but a little messy. And Tom, to answer that, Solera partners with community and digital organizations across the country. The YMCA is one of our cornerstone partners and is our preferred partner in the DCE arrangement. But if there's a site that doesn't have a YMCA nearby, we can certainly partner with other community organizations in that area. But you know, when possible in DCE, we choose the Y for their broad reach and ability to deliver these programs across the country.
Tim, do you want to mention, this is Gloria, do you want to mention some of the trainings that are coming out from CMS on further DCE training, and then also some of the office hours that the Y and Solera will be posting?
Absolutely. So as you all know, if you've been following this whole direct contract and application evolution, CMS has a series of additional webinars that will be made available later this month. One of the more important ones is on the financial model, which will be on the 15th of January, where they will provide additional detail, as well as they will have office hours to speak to specific questions. But the first office hours, or it's actually the second one, but the first one of this month of 2020 will be tomorrow. And we attend all of the webinars as well as the office hours so that we're able to understand how to best position a DCE that partners with the YMCA and Solera to have a response that meets the needs of CMS or the requirements of CMS. In addition to that, we intend to roll out our own set of office hour calls so that if there is a group, a provider that is preparing a DCE application and they want to ask some very specific questions and really get very granular in terms of how would this fit into my proposal based on what I'm proposing to CMS, and we are going to have the additional set of office hours that we're going to be providing as a free-for-all for people to call in to discuss how you could customize this process to your market. And again, this consultation is part of our mission to partner with healthcare providers to achieve their goals.
Thanks, Tim. There's another question in the inbox from Kristen. Who are you currently partnering with? Wise.
Who are we partnering with in terms of direct contracting?
Kristen, your line is open if you'd like to clarify. I think it's just in general.
Okay, so there are two numerous accounts, TNC, of partnerships between YMCAs and healthcare providers across the country. And the YMCA, the USCA, received a grant from the Robert Wood Johnson Foundation, and that's how I got engaged with YMCA of the USA. And that grant was to look at the broad range and scope of health system, healthcare provider partnership with YMCAs, identify best practice models, and elevate those best practice models. And through that work with the Robert Wood Johnson Foundation, that was funded by the Robert Wood Johnson Foundation through YMCA of the USA, we identified several broad, high-level partnerships from very densely populated markets to rural markets and everything in between. And now, and a lot of those were around value-based payment models. So YMCAs were partnering with ACOs, with bundled payment programs. And now we fully expect with the evolution of direct contracting, there will be partnerships between YMCAs and direct contracting entities. And what we're trying to do is to really help the DCE define how that partnership would evolve in a structured manner to achieve the objectives of the DCE program and obviously enhance the application according to the scoring methodology in the grading rubric.
Thank you. And we have another question in the Q&A box. Are you paid by billing Medicare for services provided or through contracting / shared savings with DCE?
So in the request for applications for the DCE, it specifically speaks to, on page 24 and 25, the patient incentives as well as the chronic disease reward program. And in that section, it defines that the DCE has to propose how they will implement those programs and how those programs will be financed as part of the per beneficiary per month rate that's paid to the DCE. So it is not an expectation that we would be filing claims. In addition to that, as you know, the DCE is a total cost of care model. So any claims would just go against the total cost of care. But CMS, clearly by their explicit definition on page 24 and 25 of the RFA, they are expecting a DCE to propose these programs as well as propose the implementation strategy and sustainability through the per beneficiary per month allocation to the organizations that will implement the program.
And again, we have another question that I think you addressed, but they might have missed it. Could you explain the cost model and the local configuration plan related to that?
Sure. So what we have developed through long history of developing programs is the creation of a broad menu of programs and services that are evidence-based and evidence-informed, as well as we take those programs and we match that to the DCE catchment area, the YMCAs that are in that catchment area, and the programs that they're currently offering, as well as the needs expressed by the DCE. And once we begin matching that, then we're able to better determine what is the cost of delivering the programs. And so we don't have a fixed rate, because there may be an area where maybe there's only one program. It's very unlikely, because in the majority of YMCAs, there's 3 or more evidence-based and 4 or more evidence-informed interventions that are available. And so we would develop custom pricing based on the market penetration of YMCAs across the DCE target area, as well as getting information from the DCE about which programs that are delivered at those Ys based on the menu of services that they have as a high priority as a DCE. And we would develop the response that you could incorporate as part of your proposal to CMS for direct contracting to include in your proposal. Obviously, our work, matchmaking with the YMCA, doing the market analysis, identifying the programs, and assisting you with your proposal submission to CMS, there's no cost to that. We're doing that as part of our mission as YMCAs to support integration with health systems with value-based payment. But then once you are approved, then the financial model that we define is the one that we would implement once you're approved as a DCE.
Thank you. Tom has a question about when the slides will be available. I will send these slides out immediately following this presentation. So if you don't receive them, and you should, but if you don't receive them, please just contact me directly and I'll make sure that they get connected to you. The YMCA and Solera team is available to follow up with you, and we will be sending out some information to keep in touch with those of you who may have interest in the resources that we discussed today and moving forward with your DCE or primary care first applications. The names on the screen right now, Dr. Gloria Winters and myself, Greg Walker. Contact information is here, and as you receive this deck today, you'll have that information. So you really don't have to write it down if you don't want to. My contact information is also on the invitation for this webinar. I'd like to take this opportunity to thank our presenters, Tim McNeil, Dr. Crow, for a very, very enlightening presentation. Also, Gloria Winters, who is our YMCA representative on the call today as well. Again, please don't hesitate to contact us, reach out to us for additional information, and I will have have this deck and a recording of this presentation available to you. The deck will come immediately following this presentation, and then the recording probably within a day. Okay, thank you all.
Thanks, everybody. Take care.
Thank you.